Research in osteoarthritis has shown for many years that imaging findings and symptoms often correlate only moderately. Large population studies have shown that some individuals with severe radiographic arthritis report relatively little pain, while others with more moderate image findings experience significant symptoms. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle. Today we're starting a new series called Knee Replacement Myths that cost people time and money. In this series, we're going to look at some of the things that people hear that can shape how they think about their knee and the decisions that follow. One of the most common is, your knee is bone on bone. For many people, those words become part of a conversation somewhere along the way. It might come from a doctor, from something written on an imaging report, or simply from how someone describes what they were told. Wherever it shows up, it can sound final, almost as if the decision has already been made. But that phrase is simply describing an X-ray image. It isn't predicting what you will experience, and it isn't deciding what the next step has to be. By the end of this episode, you will understand what doctors mean when they say a knee is bone on bone, how imaging relates to symptoms, and why the timing of knee replacement is often guided by how your knee is affecting your life. When someone hears those words for the first time, it can feel like the conversation is already over. Bone on bone can sound like the joint is completely destroyed and that surgery is the only possible next step. But that phrase is actually shorthand. It's a way clinicians describe what they see on an X-ray, not a command that surgery has to happen immediately. To understand why, we need to start with what an X-ray of the knee actually shows. X-rays do not show cartilage directly. Cartilage is the smooth tissue that covers the ends of the bones inside the joint, but it does not appear clearly on a standard radiograph. Inside the knee joint, there are actually two types of cushioning structures. The ends of the bones are covered with a smooth articular cartilage called hyaline cartilage. This tissue allows the bones to glide smoothly when the knee bends and straightens. The knee also contains two crescent-shaped pads of fibrocartilage called the menisci. The menisci sit between the thigh bone and the shin bone and act as shock absorbers, helping distribute load across the joint when we walk, climb stairs, or stand, among other things. When doctors review an X-ray, they cannot see the cartilage or the meniscus directly. Instead, they look at the space between the bones. That space reflects the combined thickness and position of these cushioning tissues. Several factors can influence how wide that space appears, including cartilage thinning, changes in the meniscus, and how the knee carries weight when you stand or walk. When those tissues are healthy and thick, the bones are held slightly apart. That space appears wider on the image. As cartilage gradually wears down over time, the space becomes narrower. When the space becomes very small or appears nearly absent in part of the joint, clinicians may describe that image as bone on bone. But even that description is still an interpretation of what the radiologist or orthopedist sees on the image, and it exists within a larger system doctors use to classify osteoarthritis. That system is called the Kellgren-Lawrence grading scale. If you've ever read an X-ray report that mentioned grade 2 arthritis or grade 4 arthritis, it's almost always referring to this scale. The Kellgren-Lawrence scale was developed in the 1950s to provide a standard way for doctors to grade osteoarthritis on X-rays. Instead of every clinician describing the image differently, the scale provides categories that reflect increasing structural change inside the joint. There are 5 grades in the Kellgren-Lawrence system, beginning at grade 0 and progressing to grade 4. Grade 0 means the joint appears normal on X-ray. The joint space is preserved, and there are no obvious bony changes. Grade 1 is considered doubtful or very early osteoarthritis. There may be tiny bone spurs forming called osteophytes. Osteophytes are small bony growths that develop along the margins of a joint as the body attempts to stabilize an area where cartilage is beginning to wear down. As these bony edges enlarge, they can contribute to stiffness because they slightly change how the joint surfaces move and glide against each other. Even when these early osteophytes appear, the joint space can still look relatively normal on X-ray. Grade 2 is usually considered mild osteoarthritis. Small osteophytes are clearly present, and there may be the earliest signs of joint space narrowing. Grade 3 represents moderate arthritis. At this stage, the joint space is noticeably narrower. Osteophytes are more visible, and there may be changes in the bone beneath the cartilage. Grade 4 represents advanced structural changes on X-ray. The joint space may be very narrow or nearly absent in part of the joint. Osteophytes are prominent, and the bone surfaces may appear denser and irregular. When someone hears the phrase bone on bone, it usually corresponds to this final category, Kellgren-Lawrence grade 4. In research studies looking at people who eventually have knee replacement, most fall into the higher end of this scale, usually grades 3 or 4. But that does not mean surgery happens automatically when an X-ray reaches a certain grade. Many people live with these findings for years before deciding that surgery is the right step. In clinical practice, the exact timing of surgery is usually guided more by symptoms and quality of life than by the X-ray grade alone. But even that description still refers only to what appears on the image. It does not automatically determine how much pain someone feels or how limited their daily activities are. And this is where an important distinction begins. The structure of a joint and the symptoms a person experiences do not always move in perfect alignment with each other. Research in osteoarthritis has shown for many years that imaging findings and symptoms often correlate only moderately. Large population studies have shown that some individuals with severe radiographic arthritis report relatively little pain, while others with more moderate image findings experience significant symptoms. The difference can feel confusing at first, but it makes more sense when we remember that osteoarthritis is not only a cartilage problem. It involves many tissues around the joint. There are changes in bone beneath the cartilage. There can be inflammation of the joint lining. Muscles around the knee can become weaker over time, especially when pain leads people to move less. Movement patterns can change, and the nervous system can become more sensitive to pain signals. All of those factors influence how a knee feels and functions in daily life, and consequently, how a person feels and functions in daily life. That's why two people with the same X-ray can have very different experiences when they walk, climb stairs, or stand up from a chair. So when a clinician says a knee is bone on bone, what they're usually describing is the structural appearance of the joint on imaging. They're not describing your pain level, your function, or your personal threshold for surgery. That decision involves a broader conversation. Total knee replacement is often considered when pain, stiffness, and activity limitations begin to significantly affect quality of life. Difficulty walking longer distances, interrupted sleep because of knee pain, or avoiding activities that once felt normal are often part of that discussion. Imaging plays a role in that discussion, but it's only one piece of the overall picture. Some people with bone-on-bone arthritis decide to move forward with knee replacement relatively soon because their symptoms have progressed to the point where daily life feels restricted. Others continue managing symptoms for a period of time with physical therapy, activity modification, medication strategies, or certain types of injections, even though their imaging shows advanced structural changes on X-ray. Both paths can be reasonable, depending on the individual situation and personal goals. However, if pain and mobility limitations become severe and persistent, continuing to delay surgery can sometimes lead to muscle weakness, reduced mobility, and a lower starting point for recovery. The key thing to understand is that the phrase bone on bone is not a timer that automatically starts counting down towards surgery. It's information about joint structure, and that information becomes part of a larger decision-making process. Costs and expectations also enter that conversation, particularly when people are evaluating different treatment options. Some interventions may offer temporary symptom relief. Others, like joint replacement surgery, are designed to replace the damaged joint surfaces when the structural changes have progressed to the point that other treatments are no longer providing enough relief. When someone understands what each treatment is designed to do, it becomes easier to weigh the potential benefits, the risks, and the timing that feels appropriate for their own situation. Before we continue, I want to mention something that may help if knee replacement is on your horizon. I created a free guide called the Total Knee Success 14-Day Launch Plan, and it's completely free to download. It provides a clear checklist for the final 2 weeks before surgery, so you know what to prepare, what to expect, and how to set yourself up for a smoother first week after surgery. It's educational. If you'd like a copy, you can download it through the link in the show notes. And if you're getting ready for a knee replacement and want to know how prepared you really are, check out the knee replacement game plan. Inside the book, you'll find the Total Knee Success Readiness Score. It walks you through the key factors that can influence your recovery, things like strength, range of motion, daily function, and lifestyle habits, so you can see where you're starting and what to focus on before surgery. It's also educational in nature. To learn more or get your copy, visit TotalKneeSuccess.com or check the show notes. Let's come back to the central question. Does bone-on-bone arthritis mean surgery has to happen right away? For some people, they do make that choice. For many people, the answer is no. Bone-on-bone describes the structure of the joint. The timing of knee replacement depends on how the knee is affecting your daily life. When pain begins limiting walking distance, disrupting sleep, or making ordinary activities like climbing stairs or getting out of a chair feel difficult, that's when people start seriously considering surgery. Until then, many people continue using other strategies to manage symptoms and maintain activity. Understanding that distinction can help put the phrase bone on bone into the context where it belongs. It allows space for thoughtful decisions instead of rush ones. If you've been told your knee is bone on bone, here are a few considerations that may help frame the conversation with your care team. First, how much is your knee affecting daily life? X-rays show joint structure, but surgery decisions are usually guided by symptoms. Pain that limits walking, sleep, or everyday activities often play a larger role in timing than imaging alone. Second, what Kellgren-Lawrence scale did your X-ray show? Many people who eventually have knee replacement fall into grade 3 or 4 on the Kellgren-Lawrence scale, but people with the same grade can experience very different symptoms from each other. Third, are your symptoms stable, improving, or gradually worsening? Some people with advanced arthritis manage symptoms for years with exercise, physical therapy, or other strategies before deciding that surgery is the right step. Fourth, what activities are becoming difficult or maybe impossible? Difficulty walking longer distances, climbing stairs, or returning to activities you value becomes an important part of the discussion about surgery timing. And finally, what outcome are you hoping for? Some people want to return to specific activities while others want to reduce daily pain. Understanding your goals can help guide conversations with your surgeon and care team. In the next episode, we begin with another belief that often influences how people approach knee arthritis. Many people are told that once their knee starts wearing down, they should avoid exercise in order to protect the joint. But movement and strengthening play a very different role in knee health than many people expect. We will explore the idea that you should avoid exercise to protect your knee and why the research around movement and arthritis tells a more encouraging story. And remember, an X-ray shows the structure of a joint, but decisions about treatment usually involve a much bigger picture of how your knee is affecting your life. Thanks for joining me today. I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at TotalKneeSuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.